On behalf of Dr. Arjuman Siddiqui, Dr. Vivek Goel, and Dr. Adalsteny Brown, with whom we are organizing this event, I want to thank you for joining us during our second day of the virtual symposium on population health, past, present, and future. My name is Mabel Caraballi, and I am a postdoctoral fellow at the Epidemiology Division of the Dalla Lana School of Public Health. And today we are going to talk about health and racial inequalities. Before to begin, I want to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to too many Indigenous people from across the Turtle Island, and we are grateful to have the opportunity to work on this island. So as I say, today we will be talking about health and racial inequalities. We have a great panel. We have Dr. Ana Diaz-Ruz from Drexel University. We have Dr. Roberta Timothy from the University of Toronto. And then we have Dr. William Darity from Duke University. I will presenting them across the symposium. But before we begin, I want just to tell you that the recordings for day one are ready, and they are ready to play at the Dalla Lana School of Public Health website and YouTube channel for you to view. So without further ado, I want to introduce you to Dr. Ana Diaz-Ruz. She is a professor and a dean of Drexel University School of Public Health. Dr. Ana is a physician, and she has been trained in public health in the University of Johns Hopkins. Before joining Drexel University, she has been working, she worked in Columbia University, University of Michigan. She's internationally known for her research on social determinants of population health and the study of how neighborhoods affect health. She is today she's going to talk about like an overview of health inequalities and a big overview of social determinants of health. Thank you for joining us, Ana. Welcome.
Thank you, Mabel. Good morning to everyone. Thank you for that kind introduction, and thank you for inviting me to be part of this very exciting series of seminars. So I'm going to share my screen. I'm going to give a little bit of an overview and provide some reflections on challenges and opportunities that I see in the field of health disparities and social determinants research and action, actually, as well. And so what I want to talk about three things. First, highlight what for me have been the three big successes of this field over the past, I don't know, 15 or 20 years. Three big challenges that I think we face. And then if I have time, I'll quickly go through a few ideas for a research agenda. So starting with the three big successes, for me, the biggest success, and this may seem obvious, but I think it's worth remembering, is that the work that's been done in the area of health disparities and social determinants in general, or health inequities, the terminology has evolved over time, has really expanded the conceptual frameworks for understanding and intervening on health and health disparities. And this, I think, is critical and very important. And this has happened in many ways. And I'm just going to show you a few figures that reflect that comprehensive, conceptualization of the determinants of health, this idea of multiple levels of influence, the idea of pathways involving long causal chains with distal and proximal causes, the idea of factors operating over the life course, the idea of underlying structural causes like racism that operate through a number of varying mechanisms. So, and today, obviously with COVID, we have seen how this notion that health is affected by much more than healthcare or much more than biology has been very visible. And I think, can be very powerful in terms of highlighting what actions we should be taking as a society to improve health in general, and of course, to reduce health inequities. And the social determinants approach, which in some ways has become somewhat mainstream, for better or for worse. I often comment, I was once at a meeting where someone from a health insurance company introduced themselves as the VP for social determinants, which I thought was quite interesting. But nevertheless, this approach, which involves factors at multiple levels, the notion that we need multiple disciplines for understanding, and then also multiple sectors for acting to improve health, and the notion that we need to move beyond healthcare. These are all key elements of the social determinants approach. This notion of a life course and also intergenerational perspective. So what we see today, a person's health today is a function not just of what their situation is today, but what it's been over the life course, and also what it's been intergenerationally. Multiple causal pathways and mechanisms involved, the complexity of it, which I'll come back to, and the notion that we need to look at the intersection of domains, a neighborhood, socioeconomic position, race, ethnicity, gender identity, etc. This idea of intersectionality affecting health. So I think this is, we can consider this a success of the work in this area that has made this much more commonly talked about than it was a while back. And of course, the recognition of looking at not just the characteristics of individuals, but the characteristics of populations. And interestingly enough, this social determinants approach has also permeated the medical world. So in some ways, medicine sort of rediscovered the social determinants. This is just one example of a report about including social determinants and electronic health records, for example, put out by the Institute of Medicine a few years ago in the US. And I'm sure many of you are involved in this kind of work. So I think, I think this illustrates the power of this broader conceptualization. The second success that I see is also an empirical demonstration and a recognition that the social world affects biology in a very concrete and measurable and significant ways. And there are many manifestations of this: the social patterning of so-called biomarkers, the understanding of stress physiology and what role it plays in health inequities, broadening the environment and the study of gene by environment interactions to encompass the social world. So the environment and gene by environment, not just age and gender, as is often commonly the case, but much more broadly to look at social context. This is something that's emerging. And also the idea that there are also social influences on gene expression itself, some of these epigenetic mechanisms that may be linked to to social environments generally. And so, there's a long history to looking at biomarkers. This is a paper many years ago looking at the social patterning of fibrinogen. This was quite novel when this first came out. And then more recent work is just an example that we were involved in looking at the social patterning of the cortisol response, for example, and its relationship to neighborhood characteristics. More recent work is really looking at the influences of social factors on gene expression and how that can contribute to cardiovascular risk, for example, and health disparities in cardiovascular risk. This is an example of a grant currently underway led by my colleague Jen Smith at the University of Michigan. So really a recognition that it's not just behaviors. Of course, behaviors themselves, we know, are constrained and affected by context, but it's not even just behaviors. It's also about the measurable biological impact of the social world. And I think that has been a second success. A third success has been this very explicit recognition of the role of factors at multiple levels of organization. So moving beyond this individualization of risk. This is a picture that I often use when I talk about multi-level analysis, but it recognizes the fact that there are all these levels and many others that you could come up with to enrich this diagram, and all these things have influence on health. And this multi-level research has really spurred thinking about constructs and variables at multiple levels, new analytical approaches, empirical documentation of these effects, and also, most importantly, not just research, but also implications for action, the implication for multi-level intervention and moving interventions out, not only within the realm of the individual and healthcare, but also to the realm of the community, to the realm of policy, to the realm of the city, to the realm of society. These are just a few examples of some work on neighborhoods and health. So these three big successes: expanding the conceptual framework, broadening the scope for research and action, social biological interactions, and the link to biomedicine very explicitly, and also this multi-level research empirical reach with multi-sectoral policy implications. So those are my three big successes. You may have others, I'm sure, and we can talk more about that. But those are my top three. What about the three big challenges? So I've chosen three that I think are the most fundamental from my perspective. And the first one is the recognizing that the causes of disparities are by definition structural and systemic. And these terms are used a lot nowadays, even in the press, but I think it's useful to think about what we really mean by these words, and what implications does this have for research and also for action, as I was saying. And I'm just going to give you a quick illustration of what I mean when I talk about systemic or structural factors with work on neighborhoods and health. This is very, very simplified way of looking at it, but hopefully it will be useful. So, we know, for example, that personal resources and preference to a certain extent, only of course modulated by processes like discrimination and other social structures affect where a person can live, residential location and area composition, and this affects the presence of certain resources in the neighborhood. And these resources reinforce residential segregation, for example, and these resources affect the location of things like healthy food stores or other resources, which in turn also feeds back into the area advocacy opportunities and power. And these resources we know may affect health behaviors, but also people's behaviors affect what's in their neighborhoods. And then we have stressors and coping mechanisms, modulating the relationship between resources and behaviors. For example, in the context of a stressful life, we're much more likely to pick up a fast food if there's a fast food place near my house, for example. And really, what I'm referring to here is that here, even though I've grossly simplified this to illustrate some of the ways in which neighborhoods affect health, we already see a number of dynamics, feedback loops, reinforcing mechanisms. And this is what characterizes dynamic systems. So dynamic systems imply that there are factors at multiple levels, that are heterogeneous and interdependent units, that there are feedback loops, that there are nonlinear effects, unanticipated effects, that there are multiple paths to the same outcome. Different people can get cardiovascular disease in different ways. And also the role of history broadly defined, of course. And this means that we see emergent patterns. Health disparities is one emergent pattern, which are not easily reducible to a single factor or even to the simple interaction of two factors. It's really a property of the way the system is structured and the way the system functions. And this means, for this reason, we often see what systems experts call policy resistance, the tendency for interventions to be defeated by the system's response to the intervention itself, or when obvious solutions fail or even worsen the situation. The individual level approach, health education, for example, although very well intended and sometimes can have some results, is not able to overcome the structure and the system that is driving these health disparities. Obvious solutions fail or even worsen the situation. And so this is why we need to think about, I think a big challenge is thinking, and there's been discussion in the field of public health and epidemiology for a number of years about this. How can we better incorporate this kind of thinking into health disparities research? What does this mean for the work that we do? And this means, from my perspective, first and foremost, broadening our conceptualization to incorporate these dynamic relationships, these features of systems into our conceptualization of the drivers of health inequity. So moving beyond these very simple models that we often draw to a more sophisticated understanding of the drivers. And this does not mean making it super, super complicated. And I'll come back to that in a minute. And also, of course, using the tools of systems modeling. And so really, the systems approach is very different from what's traditionally done in health research, because it really forces us to think about the components of the system first, and then move into further phases of analysis, which may involve simulation modeling or not, as I'll talk about later. So, you know, one interesting aspect of systems approaches is that they really force us to integrate what we know and gain insight on the implications of it, and test interventions that are not feasible yet, perhaps in the real world, identify new points of intervention, and identify reasons for unexpected effects, for example. And so I think an interesting aspect of the systems approach is that it really forces us to, in some ways, change the question. So, for example, move from a question, are neighborhood characteristics independently associated with health after accounting for individual level SCS? I think this has been an important question to answer because it has highlighted the role of neighborhood factors, but it may not be enough for full understanding and for intervention. So moving from this kind of question to a question like the question at the bottom, to what extent and under what conditions could residential segregation generate and reinforce health disparities by race, for example? Or to give you another example, from a question like, is proximity to supermarkets associated with better diet after adjusting for individual level SCS, to something like, what is the plausible impact on health inequalities of a strategy to subsidize the location of supermarkets under various spatial parenting scenarios? So a much more nuanced question that takes into consideration dynamics and that is more connected to intervention, as you can see. So systems thinking. My second challenge that I want to highlight is fully reaping the value of multiple methods. And this is closely related to the notion of thinking more systemically, because I think in order to understand and understand these systems and figure out the best strategies to move them in the health equity direction, we need multiple kinds of methods. So, causes of health disparities involve levels, long causal chains, as I said, multiple kinds of factors, effects that are conditional, for example, that, this happens only when this other factor is present. This effect occurs only when there's another factor, for example. Dynamics, as I alluded to earlier, feedbacks, dependencies, people influencing each other, neighborhoods influencing each other, for example. And this means all these things, which are the features of dynamic systems, imply that a single methodologic approach is likely going to be insufficient. And let me show you an example of this, drawing from work that we have done over the years on neighborhood health effects. These are just some examples of empirical documentation of how area features are related to certain outcomes that we think might be affected by neighborhoods, cross-sectional data, not necessarily, not sufficient to draw causal inferences, longitudinal data, a little bit closer in the direction of causal inferences, but still many challenges because it's observational data, because results are not always consistent across studies, lack of comparability of measures. The literature is sometimes difficult to summarize. And so this raises questions about, well, what are the implications of this for intervention? And for this, traditionally, we often think that we start with observation, we draw some conclusions about causes, often tentative from observation, and then we experiment. Of course, we can't always experiment in population health. The closest one close example to an experiment in the area of neighborhoods and health is the Moving to Opportunity trial, which is a randomized trial in the US, randomizing low-income households to move to a low poverty neighborhood. And they found some effects on diabetes and BMI in women, for example. Interestingly, there were some unintended adverse effects on young boys, but that's for another conversation. But what I want to highlight is that the conclusion of this study said, well, yes, we found some effects, but the mechanisms underlying these associations remain unclear and warrant further investigation. And that's actually, I think, quite interesting because it suggests, well, in order to intervene, rather than moving everyone out of poor neighborhoods, in order to intervene on neighborhoods themselves and promote health equity through neighborhood investment, we need to understand what features of neighborhoods are really important. And for that, we need to return to observation. And similarly, observation can motivate, sometimes experiments themselves can yield unexpected results. These are a few examples of experiments related to interventions on social determinants, which yielded unexpected results. And sometimes in order to understand these unexpected results, why these interventions work or why they don't work or under what conditions they might work, we need to go back to modeling, for example, simulation modeling, which can help us understand some of these conditional effects and some of these unintended consequences. So basically, what I want to highlight is that systems modeling can play a role here as well. And sometimes, very often, systems modeling, which has many caveats, many caveats, often raises more questions. And so we have to go back to observation and experimentation. And of course, in public health, there's also action itself, which must happen sometimes in the face of incomplete evidence. And we can take advantage of that action to also learn from it. This is an example of interventions to address food deserts and evaluations that were built into those interventions so that we can learn under what conditions these interventions might work. This is another example from Mabel's country, from Medellin, of a transportation initiative where we built in an evaluation on other violence-related outcomes, for example. So the bottom line is that we really need a system of collection of methods to be able to shed light on the systems that generate health inequities and the ways in which we can intervene most effectively to eliminate inequities. So really an evidence-generating system. So moving ahead to my third challenge, my last challenge, which has to do with really integrating ideologic and implementation research. I think this is a big challenge for social determinants work and even health disparities, because I think a lot of the work has been focused more on the ideologic side and not so much on the intervention or implementation or policy side. And I think this is really important. And I think figuring out ways that we can capitalize on the complementary nature of observation and intervention research is really important. And so in my view, there are two types of policy relevant questions, questions about ideology and questions about specific interventions, but there's also overlap between these kinds of questions. So they're not as distinct as I think sometimes they are made to appear. And in fact, there's a whole continuum of kinds of questions that we can investigate in health disparities research. Questions that are about broad antecedents leading to multiple causal pathways, for example, the role of socioeconomic position, or racism, for example. There are also specific characteristics in the case of socioeconomic position. Education could be one. There's a hypothetical intervention, increase the years of education. There's a practicable, in quotes, intervention, something that someone has actually already done. And then a practicable intervention under specific circumstances. And as you can see, as we move up on the slide, the breadth of the causal question increases, the complexity of the question increases too, so they're more methodologically challenging in many ways. And as we move down, the specification of the process is more refined, and it becomes more implementation science. So this is really a continuum between ideologic research and implementation science research. And I think the social determinants world needs to engage more with the whole spectrum of this work, because we really need all of it in order to both understand and act. So my three challenges: causes of disparities are by definition structural and systemic, fully reap the value of multiple methods, and integrate ideologic implementation research. So very quickly, because I know I'm almost out of time, just a few four buckets for future research. Ideologic, but in the broad sense. And so I think we continue to need work that links health and health inequities to distal and upstream determinants. And I've highlighted a few ideas on the slide. I think the work in this area is in showing these links, and COVID has shown this, of course. There's still additional work to be done. Mechanistic work that looks at mechanisms, I think, is still important, because It can legitimize the work because we demonstrate exactly how structural racism affects health, can help buttress the argument for its critical importance, for example, even though it's not strictly necessary, of course, to demonstrate the detailed mechanisms to act. Policy evaluation, I think, is also really critical, broadening the range of interventions that we look at to evaluate health impact of policies. And there has been a number of folks have been doing this work over the past few years. Implementation research, equity-focused implementation research. I've listed a few ideas here, moving beyond traditional implementation research, which tends to be very healthcare oriented, and really thinking about, in addition, the broader question of when, why, and how is research on health disparities translated into policies, a research agenda around this. What is adopted, what is not, why not? And also the process of communicating, understanding evidence about health disparities. I think the COVID situation actually provides a very interesting example to look at some of these and see what happens. I mean, do we see true changes in the way we think about policies to promote health equity, given the very stark illustration that COVID has shown us about the role of social and structural factors? So these are 4 buckets for our research agenda. Perhaps we can talk more about them in the discussion because I know I went over them very, very quickly. But just to finish up then, health disparities are, of course, big complex problems. And this is why we need multiple methods to understand and multiple strategies to act to eliminate health disparities. But at the same time, they are actionable problems. So the complexity should not be paralyzing because they are actionable. And I'll just finish up with a quote from Forrester, who's one of the the founders of systems thinking back in 1969. In the complex system, causes are usually found not in prior events, but in the structure and policies of the system. And so I think this is the challenge that we have in population health and health equity research in general. How do we interrogate the system, and how do we figure out how we can move the system in the right direction towards health and health equity? Thank you very much.
Thank you, Anna, for such a great presentation. I really like the fact that you present not only the challenges, but also the 3 successes that we have had over the time. And I really appreciate your ideas of items for the next steps with the agenda. I really like this sentence about don't shy away racism and history. I think it's very important. I think that we have to acknowledge that health inequities are a complex problem, but as you mentioned, those are problems that have actions that we could always act to try to solve this. And actually this is a great opportunity to continue and to move on with our next presenter, Dr. Roberta Timothy. She is an assistant professor at the Social and Behavioral Health Sciences Division at the Dalla Lana School of Public Health at the University of Toronto. Dr. Timothy conducts research that addresses key areas of concern in anti-colonial, anti-oppression, and community-based health promotion policy and practice. Specifically, she takes transactional and global intersectional human rights approach to social determinants of health affecting African or Black and Indigenous communities. So this put us into the health inequalities, health disparities, and racial disparities issues. She's currently working on 2 key themes that have emerged from her ongoing work on social determinants of health and anti-oppression psychotherapy. So join me to welcome Dr. Roberta Timothy.
So good morning, everyone. I want to start with a quote: "Nobody's free until everybody's free," and that's from Fannie Lou Hamer, African-American activist. I also want to give an ancestral acknowledgement. We honor our ancestors who are intrinsically linked to this land and who fought for their survival. Their lessons and sacrifices have led us to gather here today. We ask you to take a second to reflect and honor our ancestors, those who have now journeyed, who provide the footprints on which we stand today. I also want to quickly give an Indigenous solidarity statement. I stand in solidarity with the Indigenous peoples of these lands and support their fight for reparations and self-determination, as I know that their struggles are intrinsically related to my own people's fight for justice and reparations, as we are linked through processes of genocide, white supremacy, colonization, and enslavement. I vow that even though we have differences among ourselves and that the divide and conquer supported, sustained, and fueled by the Canadian state through systemic oppressions maintained by colonial powers and white supremacist ideologies will not dictate or reconfigure my connection with Indigenous, African, Black, and colonized people locally and globally. Just want to quickly outline this conversation today. I'd like to locate myself, talk about what is the situation in Canada, particularly for racial health and Indigenous health inequities. What are the major discourses in Canada? Look at a brief historical and current context, and what should we do as we look forward? So locating myself, I identify as an African diasporic woman is feminist, surviving African enslavement from a working class background, daughter of immigrants via the Caribbean, mother of two, living and resisting with a visual disability in Turtle Island. I'm an educator, researcher, community organizer, and therapist with over 25 years of intersectional anti-oppression experience. So what is the situation in Canada? I want to look at racial and Indigenous health inequities in Canada, of course, and I want to talk about some of the new or important dates that kind of have recent dates that have conversations in terms of racism and health injustice. So in 2016, the United Nations Working Group of Experts on People of African Descent came to Canada from October 17 to October 21st. A delegation of the working group visited Ottawa, Toronto, Halifax, and Montreal to gain firsthand knowledge on racial discrimination, Afrophobia, xenophobia, and related intolerance affecting African Canadians. This is a quote: "There is clear evidence that racial profiling is endemic in the strategies and practices used by law enforcement," said Ricardo Sunga, who currently has the expert panel at the end of its official visit to the country. Arbitrary use of carding or street checks disproportionately affects people of African descent. So this is kind of critical. There was a lot of advocacy in terms of resisting anti-Black racism and other forms of violence, but this was a pretty critical visit in terms of the findings from the United Nations. The Anti-Racism Directorate was created February 16, 2016. And this leads the government in terms of anti-racism initiatives to build a more inclusive society, and works to identify and address and prevent systemic racism in government policy, legislation, programs, and services. They're trying to, the Anti-Racism Act 2017, which focuses on eliminating systemic racism and advancing racial equity, are some of the major points that they're trying to bring about in terms of the change. Related documents: anti-racism data standards, Ontario's anti-Black racism strategy, Ontario Public Service anti-racism policy, Ontario's anti-racism strategic plan, and annual progress report 2020, Ontario's anti-racism strategic plan. Now, there were some funding cuts from the Conservative government in 2018, 2019, over $2 million. They since have been, the cuts have been not as great lately, so there's not cuts, but this impacted also the funding and the work of the Anti-Racism Directorate a few years ago. It's since changed. Just some other examples of, I think, documentation and materials that are important to understand health equities in Canada. Truth and Reconciliation Commission, which was from 2008 to 2015, and their findings and reports in terms of Indigenous anti-Indigenous racism in residential schools. Now it's through the National Center for Truth and Reconciliation, creating conditions for Canadian Aboriginal health equity, the promise of health public policy. It's a report that talks about Indigenous and health inequities and equities. Confronting Anti-Black Racism Unit started in 2016. Pan-Canadian Health Inequalities Reporting Initiative, a collaboration among the Public Health Agency of Canada and the Pan-Canadian Public Health Network, from Statistics Canada and the Canadian Institute for Health Information and the First Nations Information Governance Center to document in 2019. That's important to look at. Measuring Health Inequalities and Introduction and Key Health Inequalities in Canada, National Portrait. So I'm now going to talk about what I say is the major discourses in Canada, and looking at if these are helpful. in terms of population health and racial inequities. So social determinants of health is pretty commonly used. It prioritizes, though, particularly in the Canadian context, socioeconomic factors, and it's limited, has limited probabilization of race and racism and intersectional factors. It also looks at health outcomes as passive rather than dynamic, and resistance is not measured. And we're talking about resistance in terms of fighting back and how do people not only survive but thrive within the system. So that's one of the major discourses in Canada. Another one is evidence-based research. It prioritizes evidence, quote unquote, and it's quantified from often Eurocentric lens of scientific rigor. It does not demand a deconstruction of whose evidence is considered valuable, fundable, etc. It's based on a lot of white supremacist values. There's no discussion or little discussion on scientific racism and continuous impact on health research, which I think is really critical when we're looking at health disparities, particularly in racialized communities. The third discourse, I would say, is intervention research. It prioritizes interventions deemed important by institutions, governments, and often not communities who have been excluded in health research decision-making and who do not have health research decision-making and who are often the most impacted. So how do these interventions actually impact structural racism? And I would say that they don't. So what is missing? Race-based data, intersectional data, prioritizing Black, racialized, Indigenous health research and researchers, national collaborations and advisory committees in relation to population health for African, Indigenous, and purposefully marginalized populations, addressing the legacy of injustice by government funders in health service delivery and health promotion, resources and funding specifically for Black health and intersectional health is missing. Reconceptualizing health and healthcare and health reparations, a concept that I call health reparations, are what I would say is missing. So why is there racial and Indigenous health inequities? I want to quickly do a brief historical context and current context. So this is just a map of Indigenous peoples, nations pre-contact. There is many nations in Turtle Island in this land with many systems of knowledge, of health practices. This is also the pre-colonialism and indigenous civilizations of the African continent. Again, many civilizations with many knowledge systems, many healthcare practices. This is the triangular of trade in terms of African enslavement and transatlantic slave trade, which abruptly changed all of these civilizations and to where we are today, which is a colonial capitalist system. I want to talk about the historical context of health violence, which is what I call it. Canada is a white settler colony that displaced Indigenous communities by utilizing anti-Indigenous racism and other acts of colonialism violence, such as genocide and residential schools for over 400 years. The health disparities faced by Indigenous peoples are intrinsically linked to the nation building of Canada and to the continued experiences of unethical policies and governance related to the Indian Act and other colonial realities. Anti-Indigenous racism impacts the lives of Indigenous people and is intrinsically related to anti-Black racism and other forms of intersectional violence. The legacy of Indigenous racism in Canada, example, the Indian Act, which is still used today to police Indigenous folks. Example of a picture below of residential schools where children were taken away. And another example is a history of health violence in Black communities. People of African ancestry in Canada have a history of colonial violence that started in villages throughout the African region. As families were brutally torn apart, separated forever on the shores of Africa enslavement ports, that through the Middle Passage and forced migration to the Caribbean, Latin and South America, Europe, United States, and Canada, to name a few, this made up the transatlantic slave trade. Black folks that were survived were then bought as property, and generations worked with no pay and with daily experience of sexual, physical, mental, spiritual, and financial violence. The unethical practices of colonial violence in the lives of Black communities locally and globally are directly related to transgenerational trauma and health disparities, which impact Black health today. This is just an example of the legacy of anti-Black racism in Canada. The first African in Canada, 1632, the use of the Code Noir to create anti-Black policies, which still impact Black folks today. The Slavery Abolition Act of 1833, the 1867 to 1960s ban of African immigrants to Canada, which is critical when we look at the numbers of African people today. There's a reason why we have a population under 2 million. It's the basically impact of anti-Black racism. Slavery exists in Canada, kind of talking through the notion that Canada is, an underground railroad, but Canada was a country that enslaved folks. Some key policies and practices, institutions that impact health for Indigenous, African, racialized, and marginalized populations. You can see them here, British North American Act, the Right to Vote, 60 Scoop, Chinese Exclusion Act, criminalization of homosexuality, transatlantic slave trade, genocide, etc. Some examples of intersectional violence and the legacy of colonialism. I'm not going to go through all, but you can see the intersectional examples here. So Canada has state or systemic policies that affect Black, Indigenous, and racialized folks for many, many years, and it impacts health directly. Some more key policies are Missing and Murdered Indigenous Women and Girls, Bill C-35, the Cannabis Act, Canadian Mental Health Act, Children's Aid Society, Criminal Justice System, Educational System, Housing Insecurity, Food Insecurity, HIV stigma are some other examples. A little bit about health violence before COVID. So there were estimated 1,673,785 Indigenous peoples in Canada. This accounts for 4.9% of the Canadian population. Indigenous people in Canada are 2.7 times more likely to get HIV than people of other ethnicities in Canada. And this is directly related to the impact of colonization and anti-Indigenous racism. Some just other quotes here just about First Nations people living in Canada have higher rates of chronic diseases and have reduced life expectancy than non-Indigenous peoples. And of course, there's an impact between European colonization and other anti-Indigenous racist policies and processes. Some more stats in terms of just looking at the Australia Indigenous population. Canada has a bigger Indigenous population, and also looking at some stats in terms of suicide, high suicide rates, et cetera, which directly relate to anti-Indigenous racism and the impact of colonization, which I call health violence. Among Indigenous population, First Nation people living on reserve experience the largest earnings disparities. So there's also economic connections to disparities, or what I would say economic apartheid, which directly is related to the colonial and racist history of colonization. Again, this is in terms of Indigenous children in foster care, just the numbers, 52% of children in foster care under 14 are Indigenous, directly related again to colonial violence and impact of health violence. Housing violence in terms of Indigenous communities, just an example of the crisis in housing, which is directly related to colonial violence. Also the water crisis, what I call a water apartheid, and looking at the numbers of drinking water advisories in First Nation communities in Canada, it's very disturbing, and it's directly related again to not only health inequities, but health violence. And looking at the African Black population in Canada, is over 1,188,540 people. Again, I talked about, I wanted to bring the number there because it's a very small number of African people. If we look at the over 1 billion population of people in the African continent and the diaspora, which is about 160 to 200 million African folks. And this is directly related to immigrant, or anti-Black racist immigrant policies. 1 in 7 people living with HIV in Canada, 50% is African Black. This is an example of hate crimes, and these are a number of police reported hate crimes motivated by race or ethnicity. We see that Black folks are the largest numbers of people who are dealing with anti-Black racism and hate crimes. And again, it's reported hate crimes to the police, and we know that there is a distinct, not good relationship with police based on police brutality, so that we know these numbers are higher. Again, I'm making the case in terms of anti-Black racism and the result of health violence within our communities. The average Black Canadians make less annual income than non-racialized Canadians, both for new immigrants and third-generation Canadians. So even if you're in Canada for many, many years or many generations, you're still making less money than the average non-racialized Canadian. Black Canadians are far more likely than non-racialized Canadians and other visual minorities or racialized people to be unemployed. Black people make up about 2.9% of the Canadian population, but 8.6% of federal prisoners. And if we look at the history of enslavement and the creation of criminal, the prison system, we know there's a direct connection between anti-Black racism and incarceration. Across Canada, 54% of Black women sentenced to federal prison are serving time for a drug offense. Indigenous people make up only 4.3% of the Canadian population, but 38% of women and 26% of male prisoners are Indigenous. It's just another quote about criminalization and anti-Black racism. Some Black health realities. Among ethnic communities, Black women have had the most drastic increase in rates of high blood pressure, increasing from 20% in 2001 to 27% in 2012. This is just more data about the missing data that we have. We do not have accurate race-based data for issues in terms of health and Black communities. This is just an example of maternal health and cancer studies that we do not have that research, and that's directly related to anti-Black racism. Just some information about the impact, an example of a 6-year-old girl in Mississauga being handcuffed, Samuel Brown dying while Black with a disability, Caleb Smith in terms of experiencing anti-Black racism, some other facts regarding Black youth and who are underrepresented in mental health and treatment-oriented services. Linking white supremacy and racism and mental health, there's a definite connection between anti-Black racism and anti-Indigenous racism and its central determinant to mental health. And why is there racial health inequities and Indigenous health inequities? And I just want to quickly talk about during COVID, where we are in the International Decade for People of African Descent, which was recognized very late from our Prime Minister. Black people and other people of color make up 83% of reported COVID-19 cases in Toronto. This is just some statistics that you know, among Black participants, more than 1/2 had lower levels of confidence in police. 40% of Indigenous participants said that they had lower levels of trust in the court system. We talked about the declaration of anti-Black racism as a public health crisis, which we all knew about, but it's recently been declared that. The Black Lives Matters movement, the fact that Black people came out in the streets during a pandemic locally and globally, talks about the brutality of anti-Black racism. These are some of the people who have been killed by the police, and this is directly related to health impact. Dying while Black, Indigenous, Regis Korczynski, Joyce Escacon dying while Indigenous and seeking care in hospital. And this is during COVID. DeAndre Campbell dying while Black and seeking support, dying while Indigenous and seeking mental health. Chantel Moore, Rodney Levy dying while Indigenous and being at the invited gathering, and Elder Esjaz Saudry dying while Muslim and seeking mental health. These are all Canadian contexts. Woman who called cops on Black men in Central Park gets her dog back. Amy Cooper being white in New York and Canadian. Joshua Telmock, who going to school and experienced anti-Black racism. Elders Livington, Jeffers seeking health services. Just wanted to give an example of the transgendered and queer community dying while Black in terms of trans communities. And understanding African, Black, Indigenous, and racialized peoples' health and justice equals understanding colonial history and current day experience of racism and other forms of intersectional violence. What should we do as we look forward? And this is my last major points. We need to actualize and implement population health policies that are working but need funding, develop new implementable policy analysis and structural oriented change planning and processes, prioritize Black, Indigenous, and racialized population health discourse and research in public health, science, and education, among others. Think outside of the box in relation to Masters of Public Health and doctoral programs in public health and medical science. Dare to be innovative, anti-racist, intersectional, and justice focused. Incorporate decolonizing health framework as a methodology within population health. Support data collecting campaigns by us and for us with funding options for implementation of interventions and strategies for change. Critically revamp current frameworks of social determinants of health and evidence-based practice that do not use anti-oppression, anti-racism lens as central to health and well-being. Challenge discourse that creates rhetoric and not actual health justice change. Create national, local, regional, and transnational focus collaborations that focus on Black health, among others. Disrupt the dichotomy between quantitative and qualitative methodology. Utilize both and more to address real critical population health dilemmas impacting our lives today and the future. Example, resistance-centered methodology. Just want to end with a quote, Rosemary Brown. We must open doors and we must see to it they remain open so that others can pass through. And my current research is on Black Health Matters, national and transnational COVID-19 impact, resistance and intervention strategy project. Please check it out. Thank you very much.
Well, thank you, Dr. Timothy, for such a nice presentation. I really appreciate this comprehensive view about the Canadian context. Those statistics, I myself am Black, Latina, I'm a visible minority too, and I don't want to be part of any of those statistics. I really like the term that you use about the economic apartheid, and I think we will have a nice discussion around these topics. In terms of the Indigenous population, you and some attendees have raised this point of within provinces or inter-provinces racism and discrimination across the Indigenous population, which is an interesting topic that we could talk about. Something that I want to discuss later is the issue of the data. Dr. Ana Diaz-Ruz and yourself talk about this missing data about ethnicity. Um, Again, we have information, we have statistics, but information is not only not accurate, but it's not available. So I think those are important topics that we have to discuss.
Mhm.
So now we are going back to I will say to the overall view of ethnic disparities. For that, we will have with us Dr. William Darity. He's a professor at the Sanford School of Public Policy at Duke University. Dr. Darity is also the director of the Samuel Dubois Cook Center for Social Equity at Duke University. His research focuses on inequality by race, class and ethnicity, stratification and economics, schooling and the racial achievement gap, and the North-South theories of the trade and development, skin shade, and labor market outcomes. So he is a great scholar in the field of health disparities and racial inequalities. Please join me to welcome Dr. William Darity with us today.
Thank you very much. I'd like to begin by saying that a lot of my recent work has focused on the importance of making a distinction between income and wealth, and that wealth inequality has very different or significant ramifications than income inequality. Particularly when we're thinking about intergroup differences in wealth. But what I want to focus on today is the relationship between both categories of resources and health outcomes. And I want to think about not just general health outcomes, but also health disparities. And what we've discovered in the research that we've done is that there is a relationship between the level of a nation's income as well as the degree of income inequality and its performance with respect to health outcomes. And so health outcomes are better on average in wealthier communities, like higher income communities or higher wealth communities for that matter. We also find that health outcomes in general are better for communities that have more equal distributions of income and more equal distributions of wealth. And that's especially true if it's conditioned on the level of per capita income of the society. Now, in the work that we've done, we've typically been involved in measuring inequality by relying upon Gini coefficients. And so when we turn away from overall health outcomes and look specifically at health disparities, we find that the relationship is somewhat different. We don't find a clear relationship between wealth inequality in particular, or wealth levels, and the presence of disparities in health outcomes across racial and ethnic groups within a society. So we can have a very wealthy society, and we can have a society that has comparatively lower levels of wealth inequality or income inequality, but still have a high degree of difference in health outcomes across racially or ethnically marked social groups. And so I want to talk about that in a little bit of detail today. And in particular, I want to make the argument that the fact that there is no significant relationship between levels of income, levels of wealth, degree of inequality of income, degree of inequality of wealth, and social group disparities in health performance, that suggests that these kinds of changes in the stature of a community or the economic development of a community are not going to have much of an impact on the degree of inequality based upon race or ethnicity with respect to health outcomes. In fact, we could argue that those kinds of disparities are impervious or comparatively impervious to changes in the level of wealth, changes in the degree of wealth inequality. However, health disparities are not impervious to significant or substantial social policy changes. And so this is simply to say that for a society to become more affluent is not sufficient for it to eliminate or significantly reduce disparities in health outcomes across social groups. Something more has to be done. Societies have to adopt very, very specific and conscious policies to address the needs of the groups that have been most historically marginalized. So let me start with an illustration of this, which is the case of the United Kingdom, where you have a national health insurance program, a national health service, but nevertheless, you still have significant disparities in health outcomes. And these are made glaringly obvious in the context of the current pandemic. So in the UK, they tend to use this category that they refer to as BAME, Black, Asian, and Minority Ethnics. And this is somewhat similar to what I view as an unsatisfactory construction in the United States, where people talk about people of color, or they talk about BIPOC, which is a corresponding more expansive notion. And the problem I have with these categories is that they erase the particularity and the specificity of the experiences of the groups that are placed in this under this umbrella. But that said, that is how the data is to some degree collected in the UK. And it's interesting to look at what that data tells us. And this is particularly informative because, again, as I said, we're looking at a country that has universal health insurance. Do we have a reduction or a significant reduction in health disparities in such a context? And the answer is no. For example, the mortality rate among people of Black African descent in English hospitals is 3.5 times higher than that among British whites who were hospitalized. The first 11 doctors to die from COVID-19 were BAME doctors. COVID-19 was more likely to be diagnosed among BAME citizens in the UK. The BAME population constitutes about 4.5% of England's population. They are 21% of the persons who are employed in the National Health Service, and this has implications for the impact of the COVID-19 crisis. Not only do they have frontline roles generally in occupations throughout the society, especially in the transportation sector, but they have frontline roles in the National Health Service, and so they're more likely to be exposed to the virus. They are doing a disproportionate amount of the essential work in the UK, and as a consequence, they are disproportionately subjected to infection from COVID-19. So we have kind of two dimensions that are influencing this kind of disparity in a society that has a system of national health insurance. One is what happens within the system of national health insurance, both in terms of the occupational distribution by race and ethnicity in the UK, but also in terms of differential treatment of patients from the marginalized communities under the UK health system. But then the other dimension of this is what is happening outside of the hospital service or out of the health service, which is, what is happening in everyday life that affects the health outcomes for these marginalized communities. And in an environment in which you have structural racism, once again, you're going to have adverse effects on health outcomes. And that's not going to be mitigated by the presence of a universal access to healthcare. In contrast, I'd like to turn to the Australian case, where we look at the status of the indigenous population there, the Aboriginal and Torres Strait Islanders. And what we find is that this is a community that has a far higher incidence of pre-existing conditions than white Australia. So the pre-existing conditions, 3 or more chronic conditions, are present in approximately 16% of the indigenous population, whereas they're only present in about 7.6% of the white Australian population. And in the context of the previous pandemic, the H1N1 influenza pandemic, the consequences of the presence of this disparity in pre-existing conditions was really manifest heavily in terms of the disparities that occurred in exposure to and infection from this particular flu pandemic. So 15.9% of the individuals who were hospitalized as a consequence of this flu pandemic were Indigenous Australians. 16.8% of the people who were admitted to intensive care were Indigenous Australians, and 12.2% of the deaths that took place from the flu pandemic were Indigenous Australians. Indigenous Australians only constitute about 3% of the population. Now, you can certainly have a situation in which this kind of information is made available and nothing happens. But what's unique about the Australian case is that at the onset of the current pandemic, the COVID-19 pandemic, there was a significant response to what had occurred at the previous pandemic. And that significant response has led to a substantial alteration in the health outcomes. And so what we find is that there's actually a very different incidence of infection and mortality under the current pandemic than there was under the flu pandemic. The New South Wales Land Council made a conscious effort to obtain 90,000 masks at the very outset of the pandemic and intentionally distributed them among the members of the Indigenous population. The community itself was extremely active in responding to the crisis. There was no intimation that this was not something serious, that this was not something to consider as a major danger to the welfare and health of the community. And so the community collectively took action to make sure that it responded appropriately to the pandemic. But it did so in the context of the mobilization of the National Health Service for the purpose of addressing the specific needs of this community. And it's interesting to note that the health outcomes for Indigenous Australians who live in all Indigenous Australian communities, this is a case where segregation appears to have had a benefit, who live in all Indigenous communities have been much, much better than the outcomes for Indigenous Australians who live in the metropolitan areas. Let me add here that you could describe this as an instance of healthcare affirmative action, and I say that in the most positive sense. So you would have to have the combination of a very intentional policy of this sort in conjunction with the National Health Service to be able to have a significant effect on health disparities. And in this particular case, the health disparity is actually reversed as a consequence of the very, very conscious actions that were taken to provide protections for a disproportionately vulnerable community. So in our own case in the United States, of course, we have neither national health insurance, nor do we have any kind of equivalent of affirmative action in the healthcare sector for Black Americans, or for Native Americans, or for Latino Americans. And so as a consequence, we have a situation where the mortality rate from COVID-19 is 3 times as high for each of those communities as it is for white Americans in the United States. Now, there is some simulation research that I've been involved in that's being undertaken now to ask what would have happened to the kinds of infection rates and mortality rates that we're currently observing if we had had a reparations plan in place for Black Americans. And we demonstrate in a couple of these studies that we would have far lower rates of mortality and far lower infection rates if indeed a comprehensive program of reparations had been put into place on behalf of Black Americans. What's the mechanism? Well, if reparations is construed as addressing the racial difference in wealth to the extent that it eliminates that difference, then we have a situation in which it becomes possible for Black Americans to exit from low-paid jobs that place them at a greater level of danger as a consequence of the greater likelihood of being exposed to the disease. Because again, in the United States, Black Americans disproportionately hold the positions within a heavily privatized hospital system. They hold a disproportionate number of positions that are essentially frontline workers, and they are more likely to be exposed to the disease in that context. Black Americans disproportionately hold occupations outside of the hospital sector that are essential frontline positions that, again, make them more likely to be exposed to the coronavirus. And so if Black Americans had considerably higher levels of wealth, then there would be a greater degree of opportunity to exit from those positions. But in addition, there would be a greater degree of opportunity to have the kind of healthful environment and access to health care that would reduce the presence of pre-existing conditions in that community, pre-existing conditions that aggravate the vulnerability to the disease. And then a final mechanism that we've emphasized in the work that we've done has concerned housing crowding. And again, communities or people with higher levels of wealth are more likely to live in overcrowded living conditions. Overcrowded living conditions are, of course, much more conducive to the spread of any kind of infectious disease, including the coronavirus. And so, so there is this increasing body of work that's addressing the relationship between reparations and a reduction in health disparities. And again, this indicates that high levels of wealth or even falling levels of wealth inequality are not something that's sufficient to address structural racism and its impact on health outcomes. We need policies that are supportive of addressing the particular needs of communities that have been subjected to marginalization.
Thank you, Dr. Darity, for such a nice and comprehensive overview on health inequalities. I agree with the discussion of wealth versus income. We are not yet there about disentangling these differences. Your discussions, as well as the discussions from the other panelists, have raised several questions. I'm really excited about talking about them now. But before we start our formal discussion, I would like to invite everyone for a short break and take the time to answer some of the poll questions that we will bring up now. So we will have 4 minutes break to stretch our legs, and then we will be back at 11:15. Please don't forget to answer the polls. This is a reminder that we are trying to consolidate all this information from the presenters, from the discussions that we have in the chat and in our Q&A panel. And eventually we will produce a volume with all this information. Please don't hesitate to participate, post your questions in the Q&A panel or also in the chat. If you feel shy and you don't want to put your questions out there, just send Dr. Acknowledgements or myself a private message and we will be happy to answer or to put the question out there. So see everyone in 3 to 4 minutes. Welcome back, everyone. I am actually thrilled to see those poll results. So the first question was about how important do you think that is that there are people with life adverse childhood experiences and social deprivation in academic research. So this is a striking, a very important answer for a very important question. And then we have the information about the consistency. Actually, those questions are modified questions from our day 1 of our symposium. And so we frame them in the way of polls to try to motivate the discussion of today. So about the terminology, the majority says that probably is an issue, but it's not the main issue. And about healthcare and public health workers in academia trying to be engaged in social movements. So we see an important amount of attendees answering that yes, this is something that should be done. So to begin our discussion, I will invite Anna, Dr. Anna Diaz-Ruz, Dr. Roberta Timothy, and Dr. William Darity to start our panel for discussion. And perhaps I will start with what are your thoughts on the role of social movements to build power for advancing equitable conditions? Again, this is a modified question from day one, but I think it's very pertinent for today's discussion on the matter of health inequalities and racial disparities. So what are your thoughts on the role of social movements to build power for advancing equitable conditions? Perhaps Dr. Timothy, could you?
I can start for sure. Well,
yes.
I think I'm a great example of that. I come from the anti-violence movement, Pan-African movements, anti-apartheid movements, many movements in terms of Black resistance. That's how I grew up as a child, adult, now, and when in terms of having power and to make decisions about research, you have to have that political consciousness, right? And you have to be able to have actions to understand what kind of research do you want to do? Do you want to do research that continues to create colonial violence and racial disparities, or are you going to do research and actions that actually challenge the systems and try to dismantle it? So to me, it's a critical piece to have, justice and not just us research that is based on connecting to social movements. And again, I think the notion of social movements need to be critiqued though, and need to be looked at, because we use the word social movements on a daily basis, but what does that mean? And what responsibility and accountability do you have in terms of being a part of a social movements? So I think we need to unpack that a little bit more, but it's critical to continuing, I think, any type of research or any type of work, particularly in our dire times right now. Yeah.
Thank you. Dr. Darity?
Yeah, I mean, social movements are essential because I don't think anything else will happen that's truly transformative otherwise. But I think that social movements have to be conscious of what particular goals they're after. There are some instances in which it's not a question of dismantling the system. Quite the contrary, in terms of societies that actually have national health services in place, it's important to actually figure out ways in which that system can be better mobilized to ensure that we address the kinds of disparities that I was talking about. It's not a question of eliminating it. In fact, it's always the right wing that wants to get rid of national health service systems. And so we may have to have a social movement to introduce a new policy altogether, like a reparations plan for Black Americans who are descendants of persons enslaved in the United States. Or we may need a social movement to be targeted at taking an existing institution and making it operate in a way in which it actually does perform the task of achieving social justice. So yes, we've got to have social movements because the world is not going to be changed otherwise. But I think it's really important that those social movements, positive social movements, are very, very conscious of what the particular goals and objectives are that they're pursuing.
Thank you for sharing your opinion. And now I will ask Dr. Diaz-Ruz, because you mentioned this issue about actionable research or actionable things that we could use to address health inequalities overall. So I think that my first question for you will be, do you think that social movements are part of these actionable items? And Dr. Darity talks about societies and environments, and you research environments and like neighborhoods, a place where people live, has an important impact also on the analysis of health inequality. So I think that my first question is, yes, do you think that social movement could be one of those actionable items? And second, how to integrate these kind of social movements into our analysis of the society?
Yeah, those are hard questions, Marit, but important questions. So I mean, I totally agree with Roberta and William that, you know, a lot of what we're talking about in terms of reducing or eliminating health inequities, it implies major social change. I mean, that's just, you know, that's just the way it is, you know. And so, so obviously, social movements are going to be critical to creating any sort of change. We know that, you know, obviously, research is not going to create change. Researchers are not going to create change. It's really, you know, so social movements that are going to create change. And so I think what the research or the academic community can really contribute is, well, one sometimes information can be incredibly powerful and mobilizing and empower these social movements. So, you know, we saw this with the COVID data. I mean, for example, you know, the very stark statistics that were all over the press about, you know, the differential mortality that, you know, that William was alluding to, for example, between Blacks and whites. I mean, dramatic difference. I mean, this was not new. Of course, we've seen this for so many different health conditions, but the fact that it, you know, this is a piece of data, you know, information that can energize and provide, you know, focus also for social movement, right? I think the other thing we can contribute often through our research is, you know, provide, as I was briefly talking about at the end, I think a lot of the work that we often do is just kind of figuring out the mechanisms, but it can be legitimizing, because at some, you know, sometimes it's not just about saying, well, you know, the death rates are higher in this group than the other, but explaining why they are and how that is linked to structural factors, and not just to, you know, people just not behaving right, which is kind of the typical sort of, you know, kind of individualistic. It has to do with structure and context and history. You know, in the US, of course, Black-white differences are, you know, intimately linked to the history of slavery. I mean, there's no question about that. So I think linking it to history and to structure. And so I think those are some of the ways. And sometimes, you know, I think there may be new questions that, you know, that are presented by social movements that the academic community or the research community can help to inform, right? In terms of choosing, you know, what would be, you know, how can we change some of the system? How could the system be organized differently in terms of specific things like healthcare? And how can we document the impact of that? Or, you know, what evidence do we have that investing in neighborhoods improves health? And how can we use that evidence to advocate for some of these things? So I think, bottom line, social movements are critical to creating the change that we need to eliminate health inequities. And I think there are ways in which the academia and the research community can support these social movements in various different ways.
Great, thank you so much. I'm sorry to ask that question, but I'm really interested in those topics. And I actually, I'm just reflecting the amazing questions we are receiving from our panel, like questions, and the Q&A session is kind of very vivid right now. I will try to paraphrase some of the sort of questions that we have in our panel, but I want to highlight that the majority of those questions are around the issues of data, actions, and what measures are we using to assess the presence of inequalities or disparities. On that note, we know that the structural issues in the intersection between socioeconomic inequalities and racial inequalities are not new. We know that they have been existing for so long, but suddenly they are making the headlines now. So I think that one point of discussion is first, what are we doing to address that? And I know that we have done a ton of research. We have several papers on those topics. But again, going back to the point of the action and to the quality of the data that we have, not only to conduct research, but to do something that could help as an intervention or to address those things in a more active way. But what do we need to do, or what needs to be done in order to address those issues and not let them be only like the fashion or the hot topic for the moment? Because right now it is a like hot topic, but this is not new. So what needs to be done in order to seriously address those issues, to keep this topic and keep doing our research, but also keep contributing to the decrease of health inequalities? I don't know if you have any specific thoughts, but perhaps William, if you want to give your opinion about it.
Well, I think there's always the question of whether or not academic research is actually serving the public good in some sense. And some will and some won't. And some academic research actually could go against the well-being of the community at large. And so that's a danger. It's a danger we have to be cognizant of, but hopefully there will be academics who are engaged in the discourse over this type of research that will critique and challenge the work that poses dangers for the well-being of the community. I don't know how you can prevent that work from actually coming into being, just as you would not want to prevent work that is of a positive nature from coming into being. But I also think that to the extent that we're concerned about making a change in the world and doing it through social policy, we need that social policy to be anchored in sound and accurate research and data. And so, I'd be a hypocrite if I didn't say I was a proponent of what we might call, I guess the cliche is evidence-based policy. That's what I do in my life, and I think that that's what is essential. It's not sufficient, but it is an essential component of the process of trying to bring about transformative change.
Thank you. I may pose a more provocative question right now, according to what is happening in the chat, and then is, do you think that there are unintended consequences from the research? That means that by doing so much research, we are deviating the funds from more action to more research? Or do you think that this could be an unintended consequence? Or if not, are there any other unintended consequences about our research, like our work as scholars in academia, trying to assess health inequalities?
So I can talk a little bit about that. I think, as building on what William was saying, I think there are many situations where research can, for example, reinforce stereotypes or beliefs which are not necessarily, can be racist and are not evidence-based. I think one example that comes to mind in the health inequities world is, not all, of course, but sometimes genetic research can reinforce a bit of a mythology that, that health differences across race or ethnic groups are primarily genetic, even though, most geneticists will, enthusiastically agree that that's not true. But yet the research, the way sometimes it's presented or the way it comes out in the press, it sort of highlights the genetic differences and as if they were key drivers, when we know that the contribution of genetic factors to the enormous health disparities that we see are, even if they contribute, they're trivial, really, very, very small in some instances, but very, very rare, So that's one situation where research can perhaps reinforce misunderstandings about the way the world really works and what the causes really are. But this is why we need, you know, other researchers who are able to debate and discuss that evidence and point out to the problems with it, and you know, show other evidence that that counteracts that mythology about or this prejudice or this, you know, racist belief.
Yeah, this is an interesting topic because we know that the genetic makeup for African populations, for instance, is more diverse than the Eurocentric distribution of the population, but still we Black are grouped in a single category. We are subjected to the reductionism of the idea of a different race. That's an interesting topic. And then you also mentioned something about like the data, I mean, the research and the data. For that, I would like to ask Dr. Timothy, what are her thoughts about like the data availability in the Canadian context? So in the chat, people are just surprised about those statistics, about those numbers. I think that when talking about like unintended consequences of the assessment of health inequalities, we may not think about how correct are those numbers, or how those numbers, or offering those numbers or this information to the general population could affect them. There are several questions for you. I will just read a few. First is, where do we find this data for the Canadian population, some of the data that you presented? How can we advocate for race-based data? And a question for you and for everyone is, how do we change the focus from assessing health outcomes for the analysis of health inequalities, and how we move from assessing the outcome to the assessment of health status? But I will rephrase that question later. For the moment, I would like to know your thoughts about how can where could we find this Canadian data, and how can we advocate for the race-based data?
That's a good question. Where can we find this data? That's the problem, right? We're looking for data and having more access to data. I just want to say one thing about the previous conversation. I think we need to also decolonize our notions of academic. As academics, there's a dichotomy between academic and community member. I'm first a community member who does academic work and other work, also, you know, in the community. So I think our notions of what that is need to be problematized, and we're not all the same, and we don't come from the same backgrounds or locations and have the same, you know, reasons for doing research. So I think that's an important piece. For me, any research, just like any frontline work or any community health work, it's all about, you know, having a decolonizing approach. That is my political agenda. That is a part of what I do. So I think we need to sometimes look at, we're not all in the same same boats, first of all. So race-based data in the Canadian context, you know, there's been conversations about race-based data for many years, particularly African Black communities asking for data, race-based data, or intersectional-based data. You know, there was lots of conversations about having it based on the police brutality in the community, and, you know, wanting to see, you know, what the findings were regarding that, as we knew that we were having large numbers. There is a conversation in terms of government and public health. This is kind of before COVID, but still happens now in terms of confidential information, and kind of, you know, the kind of play was that, you know, this information is confidential, and we don't, you know, giving this information out from vulnerable populations will actually increase their health disparities or their chance of stigma, et cetera. Now, it's interesting that Black, Indigenous, racialized, purposefully marginalized communities are asking for data, right? So our community health leaders have been asking for data, yet the kind of governmental or institutional response is that, you know, giving the data would breach your confidentiality. So there's an impasse, or I would say more than a miscommunication that's happening. One thing that people are also talking about in the community are the differences in terms of who gets to have control of the data in terms of racialized Black Indigenous populations. So that's a critical question. Who gets the data? Who gets to analyze the data? Because historically and current day data, there's a lot of problematic realities. Look at a lot of HIV research, particularly on Black communities, and the analysis have been quite problematic, and even interventions that have been, as a result, didn't match the community's needs, and also came from stigma or anti-Black racist, anti-Indigenous racist perspective. So who gets to collect the data, what's the data that's collected, who gets to analyze the data are all important pieces of the conversation in the Canadian context. We do not have access to a lot of the data within hospital bases or in Canada. We do not have that access. There is data out there, but we don't have that access. And again, that's one type of data, of course. There's also a lot of data in community health centers, community organizations. There's tons of information about health disparities, particularly Black, Indigenous, racialized, intersectional communities that also folks don't have resources to actually go further with and support in terms of kind of bringing them up to a larger audience. For myself, I was talking about, like many folks, about race-based data and intersectional data in terms of COVID-19, and basically got tired of talking about data and decided to create a research project to collect data that looks at not only the impact of COVID-19 in Black communities, but also looks at strategies of resistance. So how communities are fighting back, what interventions are working in the community. And interventions is a word that I critique and use. So, it's kind of using both. So, how, we say things and then we use things and we have to be like, this is how we are. So, one thing that I think that is needed, that we need many different sources of data collection. And, I believe in analysis that's collected, for groups by groups. So by experts in our communities, by leaders in our community, by community members who are also leaders in our community is needed. We have a real difficult, a difficult time having conversations about this in the Canadian context. It's very province-wide. Like Ontario has some, Quebec doesn't. I know there's other. We need more of a national look, and I would say transnational. When Dr. Darity talked about reparations, I'm a global reparations person. I'm an African person of transatlantic slavery. They took me, put me in the Caribbean and Latin America. Took Dr. Darity's family, put him in the States, put you in Colombia. We need to really talk about the transnational connections of reparations and health reparations for our communities. And that interrupts a lot of the nation state and citizenship notions of not only collecting data, but health disparities. Like, we have to talk about it from a more global perspective, not international development perspective, but global resistance centered perspective. So that's what I would add to the conversation right now.
Great, very interesting.
Yeah, I wanted to make a comment, if I may, about the funding issues. So it's fairly clear that public funding is devoted more towards research activity than community action. But on the other hand, I think philanthropic funding is more directed towards what we may call community action than research. I can't tell you how many times I personally have had resistance from philanthropic organizations about funding what they refer to as research, as opposed to interventions in social action of some sort. So I think it depends upon which funding source you're talking about. And then I think we have to be very careful about which actions we are concerned about supporting or funding. I think we have to be specific about what types of actions, because certainly the federal government in either Canada or the United States is funding a host of actions, but not necessarily actions that we would view as being contributing to the well-being of the communities that we're talking about.
Sure.
Yeah, actually, those are great points. I have a question for Anna here, and it's about the systems approach. And I think that right now we have a good point to discuss this systems approach to address the issues of actions and address the issues of research. So, Anna, one of the panelists is asking you to talk more about this systems approach in terms of the research that focuses on the role of institutions and corporations in creating health inequalities. And I will also add some other question that I received in the chat, and is what could be done by institutions like university or education programs and other structures that are also the product of colonialisms, as Roberta pointed out before in her intervention. So yes, we are the product of several years of colonialism in different ways, and we are all affected in different ways. So I am Colombian, but I'm Black at the same time. And by that definition, like being just an Afro-Colombian, that changed the dynamics in how I will be seen in academia, how my research will be conducted. The fact that Roberta is an Afro-Canadian and William is an Afro-American, on top of whatever system of education we decide. So I think at those points that people are including in the channel and in the chat about the corporations and the creation of health inequalities, whether or not they are products of colonialism, are very interesting topics, and I would like to have your views on that. As I say, one of the questions was directly addressed to you and your opinion about the systems approach.
Mm-hmm. So, I mean, I guess in terms of the systems approach, I think my main point, I think, is particularly speaking to the social determinants community, I guess, of people who have been working in this area, is, sort of a call to make sure that we are not going down a very reductionist path, even with the social determinants framework, I guess. So really stepping back and thinking about the features of the systems that are driving the patterns that we see, and trying to think about that, conceptually in a more explicit way, and also think about how that impacts the questions that we ask, the methods that we use to do research, and how we interpret the results that we get. So it's not about using simulation modeling necessarily. It's about thinking, broadening the scope of our thinking, and then using a range of different methods to help us understand reality better, I guess, and in a more, realistic, really capturing what's really going on. And that, inevitably, I think that way of thinking will point us to more systemic interventions, to call whatever, which are policy interventions, right? And things about policy and things about the way our society is organized fundamentally, right? So I'm not sure if that, and obviously, corporations are obviously part of the system, right? Part of the system that we have, and part of the way our economy works, and the things that, the consequences of the way our economy is organized for health, which are many and wide ranging. So I think, I guess it's a just a call to broaden our thinking that way. And that just to reemphasize again that, systems sort of can be explored, interrogated using many methods, including, of course, qualitative methods and participant engaged, community-based methods and methods that capture the lived experience of communities. So in terms of the other questions you were asking, I mean, I think, just one reflection is that, obviously our history, our background as individuals, where we come from, what language we speak, what we look like, that affects how other people see us. And it also affects how we see the world, and the questions that we ask, and the things that are important to us. And obviously researchers are people, and therefore they're affected by all these things just like everybody else. And I think this is why it's always also so important to think about ways to make sure that we diversify, that we have a diverse set of researchers, that, we have people with different experiences, different backgrounds, different life histories, looking at these problems, because that's the only way that we're going to sort of break out of, dominant paradigms that can become a little bit blinders at some point, right? And don't allow us to see beyond the traditional thing. And I think something that has happened, certainly, I mean, in many disciplines, but I think it certainly happened in public health and epidemiology. Sometimes the method that we use starts to constrain even the questions that we ask, right? And so I think breaking out of that is really important.
Yeah, that's an interesting topic, because one of the challenges that you mentioned were like in multiple methods. And I think that this is a question, this is a cycle question, because we need better methods, but also the availability or the complexity of new methods may be a limitation to answer the question that we want to answer in the beginning. So I think that this is an important topic. We have two main topics on the chat. One is about data, and the other is about the role of families, young people, and community leaders. But before going that, I wanted to briefly mention this issue about institutions and colonialism. I think that right now, institutions overall in the United States, Canada, and all over the world, they are trying to make an effort to recruit more racialized populations, members of racialized population. And I think that this is a great effort. However, for us, who are the minorities, it is also a complex situation, because we never know whether we are being hired because we're good at what we are doing, or because we just need to be a quota in the system. And so this is more to address the issue of the colonialism and institutions. I don't know if you want to talk about it briefly. Perhaps Roberta, if you want to make some comments about this.
Well, I think the reality is that most folks who are racialized, indigenous, purposefully marginalized, in terms of what they need to do to get into, even a position in an institution that is colonial and usually excludes them, is that they usually have way more experience, way more information, way more degrees, et cetera. So even though there's publication, not all folks have publication opportunities based on, racism and other types of intersectional violence in publications, but they are usually really over qualified for positions. So I think there's some study in Brazil, I don't know the study off by my mind right now, but in terms of affirmative action in Brazilian, in terms of Africans in Brazil, and in terms of getting into colleges and universities, and it found that the folks who actually got in actually had higher grade point averages. I can't remember the study. So I think the notion that we are not as qualified, and that there's some ways that we're getting into these programs are actually pretty problematic. I think the summer of wokeness, the last 10 months, we're seeing a lot of increase in hiring in terms of Black folks, which is great. I'm like, everybody get in as if you want to get in, but what are you doing when you get in? That's the whole thing. But I do think that, we have to remember that we are working in systems that are colonial and systems that create health violence for our communities. So yeah, I think, again, if we, have kind of more of a transnational local connection, I think that we can actually do more good than harm, because we can be stronger in numbers. You said minority within these contexts of Canada and different places, but we actually are the world majority, racialized folks and indigenous folks. So it's how you think in terms of this work. That's what I would say.
Thank you. William and Anna, I have a specific question for you. I'll try to summarize what our attendees are asking. They pretty much say that communities have asked for action on their plans. Instead, the university and professors were paternalistic and asked for more data But what they say is that the community never asked for more data, they asked for justice. Data has not led to action. So what are your thoughts about this issue between more data versus more justice or more action?
I don't see them as mutually exclusive. I think that's really an odd perspective. Certainly the process of data gathering can be a deflection from pursuing an appropriate set of policies or practices within a community. It can be a way of avoiding doing what's needed. But on the other hand, I don't think that communities can take actions that are really going to be useful to them without being well informed about the circumstances that they're confronted with. I've been engaged with a number of community-based organizations in my hometown of Durham, North Carolina, who are asking quite urgently for us to get better data about the circumstances that they're faced with. And so I think it's really contingent on the particular unique set of conditions that are relevant to a community. I certainly think you cannot design sensible and effective policies without being well informed about what the conditions are. And let me give you an example of how important data can be in the context of thinking about dramatic social change. Now, I mentioned earlier that there's a body of work that I've been engaged in on reparations. And the work that I've done on reparations, particularly in conjunction with my partner, Kirsten Mullen, has focused on the notion that the amount of a reparations bill in the United States on behalf of Black American descendants of US slavery should be sufficient to eliminate racial wealth differences in the United States. And for us to calculate that bill, we have to have data about what the magnitude is of those racial wealth differences. It happens to be the case that we have learned from data that has been collected by the Federal Reserve under their survey of consumer finances, that the average Black household in the United States has $850,000 less in net worth than the average white household. And correspondingly, Black Americans constitute about 13% of the US population, but possess less than 2.5% of the nation's wealth. And so if we were going to move the Black share of wealth into conformity with the Black share of the population, we'd have to know what the number is that's required to do that. And the only way we can sort that out is by having adequate data. So I think it's really circumstantial whether or not the acquisition of additional data is something that's going to be useful or not. And I think we have to always be monitoring that and keeping in mind what's going on. I mean, certainly if we start thinking about some of the atrocious experiments that have actually been funded through federal monies, whether it's the Tuskegee experiment as one of the more classic examples, certainly that's a situation in which data should not have been collected. I mean, absolutely. But I don't think we should have any general rule of thumb that we're against collecting data. I think it depends upon the very specific circumstances.
That's a great take. And we are really near to the end of this second day of the virtual symposium. I want to thank you everyone for being here. But before we go, I want also a provoking question for Anna again, and it's about this issue of collecting data. And I am asking this question to you because you know the Latin American context. So like those days we have seen that Black communities and Hispanic or Latino communities are greatly affected by COVID-19, for instance. But we don't see that difference in Latin America. So I'm asking again because I know you know the context. But what are your thoughts on data about ethnic disparities or racial disparities in Latin America?
Well, my thoughts is that there's very little data, and that's part of the problem, right? That we, remarkably, there is very little information on race and ethnic disparities within the region of Latin America. A few countries have some, but there isn't that much. And that's, I think, having that information available, maybe some in Brazil, maybe a little bit in Colombia, but very little in very few countries. So I think that's an example where that information can be useful. But I totally agree with William's take on the issue of data, and that it really depends on the situation, whether it's important or useful or not. I mean, obviously for many things that we know we have to change in our society, we don't need any more data. That's obvious, you know, but there may be situations where data can be useful to motivate and support that action. It's not always necessary, absolutely not.
Yeah, this is a very interesting discussion. Thank you everyone for such an amazing day. I'm really happy about the discussions that we have today. Please remember that the recordings of this session will be available in the Dalla Lana School of Public Health YouTube channel next week. Please don't hesitate to contact us, either Dr. Arjuman or myself. We will try to answer any questions you may have. I want to thank our panelists. I want to thank again Anna, Roberta, and William for such a fruitful discussion. I really look forward to work with you in the volume of our discussion of health inequalities. Thank you, everyone. Please join us next week, same time and same channel. We will be talking about the major emerging insights in population health and health inequalities. We will have Dr. Sandro Galea, Dr. Laura Rosella, Dr. Michael Stepner, and Dr. David Williams. So as you have seen, this virtual symposium have a great set of panelists. I'm really happy about it. And thank you, everyone, and see you next week. Thank you so much.